substance use disorders and older adults. Next slide. And my objectives for today are pretty simple, that all of you will understand the DSM-5 criteria for this substance use disorder, because as you know, it changed in 2013. But more importantly, I'm going to be really looking at how does this criteria kind of fit, or how do you need to adapt it for older adults? Next, we're going to look at identifying very specific risk factors and treatment needs for older adults. You know, their risk factors are very different from someone who's 25 and abusing alcohol. And lastly, we are going to identify what are some evidence-based screening tools and treatment approaches, and actually also some evidence-based practices which are relevant for older adults with a substance use disorder. So welcome, everyone. I'm hoping that this is going to be a really stimulating session for you. Next slide. So I just want you to take a minute and let this sink in, this number. More than 95,000 people die from excessive alcohol use in the US each year. 95,000. It's close to double the amount that die from suicide, and again close to double than the number that die from opioids. 95,000 die from excessive alcohol every year in the United States. Next slide. In addition to this glaring number, alcohol use in particular is highly prevalent, highly comorbid. That means it's present with other either psychiatric or physical issues and diagnoses. It is very disabling, and more often than not goes untreated. And this is across the lifespan. So these stats are not in particular for older adults. I'll come to those in a minute. Only 1 in 6 report ever being asked about alcohol use. So all of you on this training today, I saw there were at least 78 and could be more. Do you routinely ask this question as part of your intake or a part of your meeting with your client or consumer? Because only 1 in 6 is ever asked. Around 14% have alcohol use. That means it's meeting clinical criteria for alcohol use disorder in any given year. 14%, that is almost like 1 in 5. Lifetime prevalence is even higher, 29%. That would be closer to 1 in 3. And of this, only 1 in 11 of these receive any treatment for their substance use. And only 9% could use treatment with medications receive them. So, and only 9% of this huge number would benefit from medication-assisted treatment, but the rest don't get it. So these are kind of shocking statistics. And why am I sharing them with you? So that you take this back to your organizations, to your community mental health programs, to your aging service provider networks, or your private practice, and say, what am I going to change? These are the numbers. What do I need to change in my practice? What do I need to change at my organizational level? So my hope is that this data informs your policies and your programs. Next slide. Here is some very specific for older adults I want to show. Alcohol-related death in Oregon in 2017, that was the latest I could get. Look at the highest bars. They are for age 65 plus. This is death by alcohol. And if you include 45 to 65, that is the highest. So it's a real problem in Oregon. Next slide. Look at cirrhosis of the liver death by age. Again, the highest groups are middle age, 55 to 64, and then the second biggest group is 65 plus. This is so, alcohol use has real impacts on everyday Oregonians. Next slide. And why am I saying all of this? Why do we care about excessive alcohol use? Decreased excessive alcohol use is associated with decrease in death, in liver cirrhosis deaths, impaired driving and crashes, crime and domestic violence, STDs, and certain cancers. All of these decrease if we are able to identify and treat people who have excessive alcohol use disorder. And currently, it costs Oregon $3.5 billion for this problem. That is, if you look at that, that is $2 per drink consumed goes towards just this cost, the cost to the economy, and in lost productivity, healthcare, criminal justice, motor vehicle crashes, all of that. So it's a very, very important issue. Next slide. And the bottom line is age-related changes in the body mean older age groups are more vulnerable to the harms of alcohol. And if any of you do psychoeducation as part of your practice, whether you're a therapist or you're a case manager in APD or other aging service, I would suggest you print this slide out and share it with your clients or with your large groups. Age-related changes in the body mean older age groups are more vulnerable to the harms. And that's why those high rates of alcohol-related deaths that I showed you in Oregon and liver cirrhosis. Next slide. So why do we have this older adult behavioral health initiative that Angela is a part of? And they are sponsoring this today. Why am I at the state level appointed as the project director for this? Why? Because there is a demographic imperative. Next slide. Look at this trend line. This is individuals 65 years and older in the total US population. And as you can see, this trend line is only going up. We are at 2020 currently, and in Oregon, we are close to 16% of Oregon's population is 65 plus, which is about 1 in 5. In 10 years, by 2030, when it will be closer to a little over 20%. Why? Because we have this entire cohort of baby boomers who began turning 65 in 2011. And that will continue till 2030, when the last of the baby boomers turns 65. And then it continues to increase right up to 2050. There are two other significant demographic changes happening within a short time. In 2034, which is 14 years from now, United States will have more older adults than people or individuals under age 18. That means our birth rate will have dropped precipitously, and our population will be aging. And why am I telling you this? It's going to have profound impacts on our social policy and on our healthcare policy. Who's going to take care of our older adults when we don't have any younger people coming in, or where there's limited workforce? So those are all really critical questions. And then in 2040, the population of the United States in the aggregate will no longer be predominantly Caucasian white. It will predominantly be brown and black. So there are huge shifts happening in terms of age and in terms of race, ethnicity, and all of this is kind of comes together. It's a confluence with an aging population. Next slide. So the demographic impact, I already told you, 10,000 Americans turned 65 since 2011. This is the baby boomer population. And the fastest growing segment is age 75 plus. And recently I saw a slide where it was showing 85 plus. And what does that tell you? Why should that be important? That the fastest growing segments are people who are 75 and 85 plus. Because we need to figure out, are these individuals healthy? What kind of caregiving supports do they need? What kind of residential supports do they need? If that is the segment that is growing fastest. So next slide. And so what is unique about this generation, this baby boomer generation, which is aging and coming in? Next slide. So substance abuse disorders in older adults is expected to double. And so it has doubled because we are in 2020. It was 2.8 million in the early 2000s, and it has almost reached 6 million. 6 million people who are older adults. And I told you some of those statistics earlier. Older adults are prescribed and use more medication than any other age group, and use more than 1/3 of all medications in the United States. And you must be maybe wondering, why am I saying these two things together? And you'll see shortly why. Next slide. So what are the unique risk factors? Remember in my introductions, I said the risk factors for older adults are very different from someone who's 25. So what are the risk factors that put people at risk for substance use disorders when they're older? Retirement and life transitions. Yes, that's a risk factor, especially when you haven't prepared for it, especially when it's not terribly voluntary, especially when you don't look at this as a new developmental phase in your life. It becomes a risk factor. And life transitions would be moving from your home to maybe a residential setting because you need assistance. That's a life transition. Bereavement, and this could be multiple losses, not just loss of a spouse and partner, though that is the most significant. It could be loss of an adult child. It could be loss of income, status, role, mobility. So lots of losses. Loss of a sense of purpose. I don't know why I'm here. What is my life worth now that I'm no longer a foreman or a teacher or a social worker or a mental health specialist or a doctor? What's my purpose? Do I have anything to give back? Social isolation and loneliness is huge. And I know sometimes we group these together, but they're two distinct issues, but they are a risk factor. Functional decline in all areas. It could be mobility, it could be vision and hearing, it could be you just have low energy, but clear functional decline. And then boredom. You have all this time, your day is not any longer kind of scheduled around your work or some important role that you had, and you're bored because you don't know what to do. Next slide. And then you have some very real physical risk factors that I want to elaborate a little bit on. Chronic pain, physical disabilities, and especially those that reduce your mobility. And many older adults have to give up driving, which then further augments isolation. Aside from it being being a blow to one's ego that you can no longer drive and someone takes away your keys. We talked about transitions in life, or in care, or care transitions. Chronic physical illnesses, most people on Medicare age 65 plus have 3 to 5 chronic illnesses. It could be arthritis, it could be hypertension, diabetes, COPD, you just name it. And polypharmacy, multiple medications, which could also put you at risk for abusing medications, and also, that they are a danger because many of them could be contraindicated with alcohol, which then creates or exponentially increases your harm. So next slide. But, everything is not doom and gloom. There are protective factors too, and that's what I would like you all to really promote within your communities and within your practice. Resiliency, marriage or any committed relationship, these are protective factors. Not just for substance use, for quality of life. Supportive family relationships, Retirement when it's voluntary, where it is voluntary, you've thought about it, you've planned for it, and you know what your next phase is. Your ability to live independently. And I tell everyone who will listen, that lower body strength, which is your leg strength, is the holy grail of aging. Because if you can walk, you can live independently much longer. So your ability to live independently is a protective factor. Access to basic resources. You have a positive self-image. And, you must say, duh, why are you saying that? We live in a culture which glorifies youth and beauty. And very often, the only pictures of older adults you see on television is where they are hawking some cream for wrinkles. That means you don't look good, get rid of these wrinkles. So it's sometimes very hard for some people who are not resilient to really have a positive self-image about growing older. So having a positive self-image or having a strong sense of who you are is a protective factor. Well-managed medical care. Now, isn't that a dream? And proper use of medications. Sense of identity and purpose. I know who I am and I know why I'm here. And I know what I'm going to do in the next phase of my life. And obviously supportive networks and social bonds. And I can't emphasize this more. In fact, this is part of what makes you resilient is your network of friends and family. So these are all protective factors. And this is what you can promote, or you can teach your clients who want to be resilient, who want to increase their protective factors. Next slide. And here are some reasons why older adults either use alcohol or medications: to elevate their mood, to mask a depression, to increase ability to sleep because they are having problems with insomnia, to decrease pain, to deal with social pressure, especially when you're living in congregate communities, where happy hour is there and drinking is considered, a part of the culture. So to gain acceptance into those groups or cliques, and then to relieve boredom. So these are all the reasons which, as you can see, are very different from younger people. So with that said, I'd like to move on to DSM-5 criteria, which is the next slide. As you know, DSM-5, so we are in the 5th edition. It came out in 2013. And it dramatically changed how we view substance use disorders in terms of, how we assess and give a diagnosis. But what I like is that DSM-5 also came up with these 4 big themes, and which basically describe what a substance use disorder is. So for all of you on the phone, on the training, a good way to remember this is the 4 C's, C as in cat, of substance use. Craving. You are constantly wanting it. You can't stop wanting it. Compulsion. You're constantly looking for it. Consequences. You use it despite dire consequences. And ultimately, loss of control, where your brain is totally hijacked by the substance. So this is a good way to sit down and talk to someone about what the disease of addiction is. Craving, compulsion, consequences, loss of control. But here is the criteria, and I'm not going to spend a lot of time on the DSM-5 criteria. Next slide, because I want to focus on how to apply it to older adults. Taking in larger amounts or for longer periods than intended, unsuccessful efforts to cut down, spending a lot of time obtaining the substance, which is that compulsion piece, craving or a strong desire to use the substance. You constantly have this craving. And that is what medications treat as the craving. Next slide. Continued use despite recurring social or interpersonal problems. You give up important activities or you reduce them. You continue to use it in physically hazardous situations. Persistent, recurrent physical or psychological difficulties from the substance, and then this use results in failure to fulfill major role obligations. So that is the 11 criteria in DSM-5. Next slide. And then you can further classify or qualify them with the tolerance of withdrawal. But next slide, what I'd really like to look at is how do you make the diagnosis? So if you have 2 or 3 of any of those 11, it's considered mild. You have a mild disorder, okay? 2 or 3 of those 11 criteria. 4 or 5, you have a moderate disorder. And if you have 6 plus, you have a severe disorder. So you can see this is very different from DSM-4. So basically, when you diagnose someone with whatever substance abuse disorder, you will qualify it as mild disorder, moderate, or severe disorder, depending on the number of criteria that has been endorsed. Okay, next slide. So I want to briefly look, and I'm not going to go over every one of this just because of time, but really want to look at how do you apply this to older adults, this DSM-5 criteria. For one, the first one, a substance is taken in larger amounts over a longer period than intended. So for older adults, maybe more self-monitoring may be a challenge if they have mild cognitive impairment. So, so this may not be the best way for you to ask. Okay. And then number 3, a great deal of time is spent in activities necessary to obtain the substance, use the substance, or recover from its effect. While in older adults, consequences can occur from even a very small amount. So you don't have to have huge amounts and that you're constantly looking for it. Remember, I said because of aging bodies, the effects are much more harmful even in small amounts. So you need to be cognizant of that. And then there's craving or a strong desire. So in older adults, remember if they have had a lifetime of substance abuse, this has become entrenched as a habit. So they may not recognize it as a craving. Very important is the next one. There is recurrent use resulting in major role failure. Role obligations may not exist for older adults in the same way as younger people, because of retirement. Role obligations more common in late life are caregiving for an ill spouse or a family member, or that you are taking care of a grandchild. So those would be kind of the role obligations as opposed to being an employee or being a father or something like that. Okay, next slide. You are going to get the slides, so I'm not going to go over every one of them. And then next one is important occupational record are reduced. In general, older adults engage in fewer activities regardless of substance use. So this may be difficult to apply to them. It could be due to just they're doing less because they are tired, they have low energy, they are in pain. So this may not be the best criteria. So you may need to tease it out a little more. And then substance use is continued despite knowledge of having, psychological and physical problems. Older adults may not realize that that this is really coming from their substance use. They may think it is their medical diagnosis and be less concerned about it. So again, you need to tease it out. Next slide. And I'm not going to go over this, but I am going to let you, you will be getting this. So please take a look at these DSM-5 considerations for older adults. And so how can you apply the DSM-5 criteria, which was really developed for, younger age cohort to the older cohort, okay? So with that said, I'd like to move on to what are the substances that older adults abuse the most? Next slide. And you guessed it, the most common is alcohol. And that's why I've been referring to alcohol use disorder, because for this current cohort, alcohol is the most common substance, followed by nicotine, then by psychoactive prescription medications, and lastly, other legal and illegal drugs. And this could very well change as the younger cohort of baby boomers comes into being older adults, but currently alcohol is the number one reason, number one substance. Next slide. So alcohol is a substance that older adults use and misuse most frequently. One of the 2019 reports found that in individuals aged 65 and older, an estimated 5.6 million or 10% of the population engaged in past month binge alcohol use, and an estimated 1.5 million engaged in past month heavy alcohol use. So what they are saying is 10%, or actually closer to 11% of older adults age 65 engaged in the past month binge drinking, which is 3 or more drinks on one occasion. That's binge drinking. By the way, that's the fastest growing kind of drinking problem, is binge drinking. And then 1.5 million, or close to 3% of this older adult population. Remember, we said Oregon has 16%. So 3% of that population engaged in heavy alcohol use. So that's pretty startling. That was last year. Next slide. Chronic pain is defined as non-cancer pain that continues 3 to 6 months past the time of formal tissue healing. And it's very difficult to treat. And it is, guess what, increasingly common in older adults, affecting as many as half, including up to 80% of nursing facility residents. So huge, huge problem, chronic pain. Next slide. And so this chronic pain puts them at risk for opioid use disorder. They have a higher prevalence of pain. They make more clinic visits due to pain, and they are on higher rates of psychoactive drug use compared to younger cohorts of this older age group. Next slide. So what do we know about pain and alcohol use? Older adult alcohol drinkers report more severe pain. That means, those who drink heavily report that they have more severe pain. They have more disruption of their daily activities due to the pain. They use alcohol more often to manage pain. So, and the more the pain, the more alcohol they use. So we already know this, that this relationship exists. Next slide. And drinking alcohol further impairs your functioning when you're older. Among older men and women, more than 7 drinks per week was associated with impairments in what we call instrumental activities of daily living, which are those higher level independent living skills, such as financial management, medication self-management, household chores, being able to budget and cook and clean and, all of that, that gets impaired. And more than 3 drinks, which is binge drinking, was also associated with impairment in these IADLs. So very significant. Next time. And look at medications. Earlier we talked about opioids. Now this is just medications broadly. An estimated 1 in 5 older Americans may be affected by combined difficulties with alcohol and medication misuse. And I'm glad Angela has scheduled a training in middle of November on polypharmacy and the older adults. So 1 in 5 is affected. Next slide. And look at the medications which interact with alcohol. It's almost all medications which your family member or your client or patient or nursing home resident is on. Benzodiazepines, sedatives, opioids, anticonvulsants, some psychotropics, some antidepressants, barbiturates, cold allergy medication, aspirin, you just name it. Alcohol interacts with that. So it puts you at high risk for harms. Remember, I said with older adults, because of aging bodies, alcohol puts you at harm, places you at harm. Next slide. Going back to medications, in particular opioids, 1 in 3 Medicare Part D beneficiary received an opioid prescription. 1 in 3. Can you believe it? 1/3. And of that, 500,000 received a very high dose of opioid. Almost 90,000 were at serious risk of addiction. Of those 500,000 that received very high doses, almost 90,000 were at high risk. And these are older adults. Most people on a Part D prescription drug benefit are 65 years plus. Yes, there could be some younger disabled people. For the most part, they're 65 years. And more than 6 out of 1,000 Medicare patients are diagnosed with an opioid use disorder, compared to 1 out of every 1,000. So 6 out of 1,000 for Medicare have an opioid use disorder, while 1 out of 1,000 for commercial insurance. That means commercial insurance includes all age groups. So you can see how it's skewed here. 6 out of 1,000. That means because of those, 1/3 of them receiving an opioid use disorder with very little education and even less health literacy about what's the harmful effects of opioid. Next slide. Again, some shocking statistics. Annual opioid prescriptions for Americans aged 65 and older more than doubled. More than double the amount received by adult younger than 65. So what someone gets when they're age 65, the prescription is more than double what someone younger gets, which is kind of illogical, right? It should be going in the opposite direction. We talk about a geriatric dose, but here it's just the opposite. Older adults with chronic and acute pain obtained an average of 774 morphine milligram equivalent, so MME, of opioids annually, compared to 376 MME a year for people who are not under the age of 65. Can you see that? They are getting half the amount. Do you know what is the recommended dose? 90. But regardless of that, what this slide is showing that older adults are getting 774 MME compared to younger adults at 376. It should actually have been opposite. So these are all startling statistics. And next slide, what do opioids do for older adults? Next slide, high susceptibility for cognitive and motor effects. Older adults taking opioids are 4 to 5 times more likely to fall than those taking NSAIDs. And what do falls do? They are the number 1 reason for traumatic brain injury in older adults, for hip fractures in older adults, and for death, falls. In addition, it also increases cognitive decline. If you already have a dementia, it makes it worse. If you don't have it, you're kind of confused. It also kind of increases your depression and puts you at greater risk for suicide. So this is very serious. Next slide. Look at benzodiazepines. How many of your patients, consumers, clients are on benzos? They also increase fall risk. In fact, it's an independent variable for falls, benzos. It impairs your cognitions. It can lead to overdose death, motor vehicle accidents. So this is, again, abuse of this medication. Next slide. And look at this emergency department visits. The number one reason was prescription or non-prescription pain medication. Number one reason. Followed by narcotic pain, benzos, and then alcohol was fourth. But that was those, the top four, three of them were for medications. The last one was for alcohol. Very serious. Okay, next slide. So I want to talk very briefly about thiamine deficiency. Why is that important in older adults? For you to check that. So thiamine is essentially B1. It is a very essential nutrient, and your body doesn't produce it. So you have to get it from food or from a supplement. Thiamine deficiency can be caused by a poor diet, inflammation of the stomach lining, which can cause vomiting and depletion of thiamine, and damage to the liver. And alcohol can affect the conversion of thiamine, not only because of poor diet, but also it actually affects the conversion. And when you have a deficiency in thiamine, which can result from chronic alcohol use, you can cause what is called Wernicke's encephalopathy, a life-threatening medical emergency, which is only rectified by giving you thiamine. And so it would behoove all of us who work with older adults, and we know that maybe they're drinking heavily, that you should assess their risk for thiamine deficiency. Next slide. And many of you have then heard of, so one is the Wernicke's encephalopathy. The other one is Korsakoff syndrome, also called alcohol dementia. And this is a neurological condition which often, but not always, is preceded by Wernicke's encephalopathy. I would say more often than not, it is preceded by Wernicke's encephalopathy, though not 100% of the time. Chronic severe thiamine deficiency, what leads to this is chronic severe thiamine deficiency due to malnutrition and alcohol use. That's what Korsakoff syndrome is. Next slide. So how does alcohol affect cognition in older adults? Alcohol misuse. Korsakoff syndrome and its associated thiamine deficiency is not the only mechanism through which heavy drinking contributes to cognition, to chronic thinking changes and cognitive decline. Alcohol misuse also leads to brain damage through direct toxic effects on the brain, biological stress of repeated intoxication and withdrawal on the brain, alcohol-related cerebral vascular disease, and head injuries often sustained when you're drunk. Someone asked, I saw in the chat box, how can we assess for thiamine? It is a lab test. So, it would have to be a primary care provider of some kind ordering a lab test. So alcohol, aside from Korsakoff, it also affects the brain and leads to cognitive decline in all these other areas. Next slide. And why are older adults so susceptible? We've been talking about aging bodies. Alcohol and drugs affect older adults differently due to biological changes associated with aging. And for all of you on the phone who are on the virtual conference, who do psychoeducation, who may not be therapists, but would like to give some educational materials to your clients, I would suggest you print this out and give it to your clients. And this comes out of SAMHSA, this little infographic. But if you can move to the next slide, I want to talk about what are the biologic risk factors. What are the risk factors with aging bodies? The body's ability to break down alcohol in the liver is reduced. Older adults are more susceptible or sensitive to the toxic effects of alcohol because of this. And that they're more likely to be on multiple medications. I just told you 1/3 of all prescriptions written in the United States are taken by older adults. And so what happens with all of this? Alcohol concentration in the blood is likely to be higher in older adults because as we age, our muscle is replaced by body fat, and alcohol is not drawn into fat as well as it is drawn into muscle. So what happens is you have more serum alcohol available in your body floating around, and you're not absorbing and eliminating it because you have more fat and less muscle, and you have less efficient kidneys and livers. And so what happens? And you're on multiple medications which could be contraindicated. And guess what happens? Very soon, as an older adult, you're experiencing toxic effects. Next slide. Look at all of the health consequences or health diagnoses which can get exacerbated. Bone density, falls, impaired immune system, especially if you're not eating well, malnutrition, poor, impaired cognition, depression and anxiety, because alcohol is a central nervous system depression. Cirrhosis, I already showed you the slide at the very beginning. Hypertension, so lots of impacts from alcohol use. And the next slide is a very nice infographic, next slide, which again, I would highly recommend you copy and give to your clients, which tells you all of the areas that get affected as we age with our aging bodies, what happens. And look at drinking is also linked to 7 major kinds of cancer, including breast and colon cancer. So huge impacts. Just a word about liver disease and cirrhosis. Long-term alcohol consumption is a major cause of chronic liver disease and cirrhosis. Continued alcohol use over time causes scar tissue to build up on the liver, preventing it from performing critical functions such as managing infections, removing harmful substances from the blood, and absorbing nutrients. In Oregon, over 600 deaths were due to chronic liver disease and cirrhosis, and this is for all age groups in 2016, and more than 4 in 5 of those were directly caused by alcohol consumption. So the majority of deaths by cirrhosis of the liver were preventable. So next slide. So when I've given you all of this doom and gloom and scary stuff, what do you tell your client now in terms of education? What is a drink? Here you can see this picture. My doctor said only one glass of alcohol a day. I can live with that. So what is a drink? Next slide. And here are the federal recommendation for drinking limits. Look at age 66, all ages, men and women, no more than 7 drinks per week, which means 1 drink a day. And no more than 3 drinks per day, which is considered, if you drink more, then it's considered binge drinking. And if you can look at this chart for women, it is 1 drink a day across the adult lifespan, even for younger women. Not for younger men. Younger men under the age of 65 can have 2 drinks a day. Everyone age 66 plus, 1 drink a day. Next slide. And so what is a drink? This is the measurement. Again, please print this. 12 ounce, 1 12-ounce can of beer. How many of you know of people who drink a 6-pack a day? Older adults. The recommendation is 1. And by the way, for younger men, it is 2. And for women, it continues to be 1. Look at table wine. 5 ounces of wine. And less so for fortified wines like sherry or port. And look at a liqueur, 2 to 3 ounces. Brandy or cognac, 1.5 ounces. And look at hard liquor, which is distilled spirits, 1.5 ounces. I think if I'm correct, it is like 1 jigger. That's what a drink is. That's what they have to limit it daily to, one of those, any one, with the correct measurement. Let that sink in a minute, okay? 1 can of beer and 1 5-ounce glass of wine. Next slide. Just a word for women here. Sorry, ladies, but you can't drink as much as men, and that's not a male conspiracy theory, but a biological fact. Women have less body water than men, so the concentration of concentration of alcohol in their bloodstream is proportionally higher. Also, women have more fat than muscle, and so if a woman drinks a double gin, the man of the same size will have to drink a triple gin to reach that same blood alcohol level. In addition, so there's there's more body fat, less water in women's bodies. And there's some evidence that women may have smaller amounts of an enzyme that breaks down alcohol in the liver and in the lining of the stomach. And this might also contribute to higher BAC levels. That's why the recommendation is 1 drink for all adult women, 18 years and older. I'm not going to go, so this is, next slide. This is just an interesting fact, that people sometimes say, how the face changes with chronic alcohol use. If you drink heavily, alcohol actually dehydrates your body and skin. This is because it blocks the release of antidiuretic hormones. So kidneys get rid of too much water. And too much alcohol then dilates the blood vessels under the surface of your skin, which can then lead to these broken veins on the nose and cheek, kind of that ruddy kind of look. That is what alcohol does, because it kind of dehydrates your skin. So next slide. So just a word about blood alcohol level. And I know we have many people on the phone, some of you may be more familiar with it, others may not. So I'm just putting in a slide. It is the amount of alcohol in your bloodstream. And it obviously depends on how much you drank. The more you drink, the higher your BAC. But also many other factors affected, like your weight, your size, your gender, like we just said, and what you've eaten. If you eat and drink, that's better than not eating and just drinking. And that is what is measured. Okay, next slide. And in Oregon, it is illegal to drive with a BAC at or above 0.08%. In Oregon, that's the law. Next slide. 1,176 people were killed in crashes involving an alcohol-impaired driver in Oregon in 9 years, from 2009 to 2018. Close to 1,200 people lost their lives. Next slide. So drinking and driving is dangerous. So what's this thinking distance? Alcohol's effect on the brain slows down a person's reaction time. So what that means is they take longer to respond to hazards, such as someone running in front of a car, or a dog running by, or someone swerving into your lane. It takes longer for you to respond. So if a cat ran in front of your car and the delay between you seeing it and putting your foot on the brake the extra distance you travel is called your thinking distance. So each drink increases the thinking distance by 20%. Remember, one drink is recommended. If you have 2 drinks, if you're age 65, it increases the thinking distance by 20%. The risk of someone being in an accident increases by 2 times for drivers with a BAC of 0.05, 4 times with 0.08, and 20 times for 0.15. Drivers who have been drinking also underestimate the distance and speed of other vehicles on the road. They tend to be more disinhibited. Their vision is affected, slowing reaction times further, and they overestimate their ability and drive recklessly. So the combination of all of this is a deadly outcome. And I just showed you 1,200 innocent people died. Next slide. So I've given you lots of facts, figures, health impacts, aging bodies. So what are the barriers for us assessing for any kind of substance use in older adults? Research in the field is primarily with younger people. Very big one is lack of training among substance use and mental health counselors on the specific needs of older adults. So I'm glad all of you are here today. Then there is stigma, guilt, and shame. So older adults don't feel comfortable talking about it. Ageist assumptions, we all have them. And downright failure to recognize symptoms. All of these are actually barriers for us to really reach out to older adults who need our help. Next slide. In addition, there are some other challenges within substance use disorder treatments. Care coordination, mandatory reporting, this 42 CFR Part 2, which is the confidentiality and the release of information part, but you can use it for care. You can bring information which is within the context of care coordination and mandatory reporting. Then multiple health problems. And then access. Medicare, the access to substance use disorder treatment is very limited. And most programs are not designed for older adults. There are very, very limited age-specific substance use programs across the country, leave alone in Oregon. So those are all the additional challenges. Next slide. So how can we help all of you recognize symptoms, signs and symptoms? Next slide. And here I have a huge, next slide, I have a huge list of symptoms which you should explore with your client. Could this be due to alcohol? Anxiety, blackouts, poor personal hygiene, increase in depression, increase in confusion and disorientation, mood swings, falls, and unexplained bruises and burns, increased family problems, increased incontinence, very poor nutrition, so they're presenting as malnourished. Legal difficulties, can you see some of them you wouldn't think of with younger people, but this is what you need to be looking out for. You should leave no stone unturned when you're trying to determine, is this an alcohol problem that my client is experiencing? Next slide. And so within this group of older adults who use alcohol, we have one group that we call early onset and another group that is late onset. So what are the characteristics of this early onset group? Here, the risky or harmful drinking pattern is prior to age 50. So it's kind of almost like a lifelong adult pattern. Long-term denial, which obviously complicates treatment, that I don't have a problem. multiple medical comorbidities. You may have 3 or 4 other medical problems like diabetes or COPD or something else. Very limited social support, poor emotional skills. And you may also be having some early dementia, whether it's due to alcohol or whether it's due to Alzheimer's disease. More common, making up 2/3 of this. So this is more common, the early onset. And almost 2/3 of older adults who have an alcohol use problem fall into this group. Now, the other group is the late onset. They began misusing alcohol much later in life, probably. So, and they could have been doing this, periodically earlier, but it generally begins much later in life. And usually this began because of an age-related stressor. Remember the risk factors we talked about right at the beginning? It could be retirement, it could be death of a spouse, it could be loss of an income, whatever it is, the misuse is very much related to an age-related stressor. It is preceded by stable periods of abstinence or low-level social drinking over long periods of time. And for many of us, it may appear healthy to raise concerns, but that is the second group, which is the late onset misuse. Next slide. So this early onset group, if Kelly, if you can just hit the bullets, will show up. They are more likely to be men, long-standing problem, more physical problems, and they've made numerous attempts at treatment. So that's that early group, which is, 2/3 of older adults have this problem. Next slide. And if you can do the similar thing, late onset, more likely to be women. And like I said, problem began related to some age-related stressor. They generally have greater life satisfaction, and they're more successful in treatment. Next slide. So it is very important for you, all of you on the phone, to recognize the difference between early and late onset. Because guess what? Diagnosis and treatment planning differ for older adults who have a history of substance abuse and those who develop problems later in life. For example, older adults who drink because of late life stressors such as loss may not have the same chronic co-occurring medical conditions or mental disorders that older adults who have been drinking for a lifetime have. Late onset substance use misuse may respond well to brief interventions. And older adults who are in that first group, chronic misuse group, may need more intensive SUD treatment. So can you see? It's very important for you to kind of make this assessment that is this early onset or is it late onset, because your interventions and your treatment plan will be very different. Next slide. So here are some, remember in my introduction, I said we're going to look at some screening tools. Here are some screening tools, and I'd love to know, y'all can just put it in the chat, how many of you use any of these screening tools routinely? For you to identify your client's level of alcohol consumption, whether, quantity, frequency, binge drinking, a very good tool is the audit, which is the Alcohol Use Disorder Identification Test. It was developed by the World Health Organization, is widely used. Okay. Consequences of alcohol. So that is, you're just trying to make an assessment. So use the audit, which is a 10-item screening tool. If you want to look at some consequences, CAGE. How many of you use the CAGE? CAGE is a very short 4-question assessment tool. You can use the audit again. Then there is MAST, which is the Michigan Alcohol Screening Test, which is kind of longer. It's 25, items. The SMAST is the short version of the Michigan, which is 13 items. And the one that we're going to look at on the next, when we'll come to it shortly, is the SMAST-G, which is the short Michigan Alcohol Screening Test Geriatrics. So I'd love for you to put in the chat box if any of you are using any of these tools routinely. Next slide. And here is the SMAS-G. This is free to download. You can just Google it, it'll come up. Or you can also print this slide. Here, it is 10 questions. It's not huge. And we have also explained what the screening, how you interpret the scores. 2+ is considered an alcohol problem, and a brief intervention should be conducted. There's an extra question at the bottom, as you can see. That should not be included in your score. It's just for your information. Okay? So I would highly, highly recommend use of this tool. And at the end of the training, we have an important question for you. Next slide. Older adults who misuse substances may not set abstinence as their goal. It may not be the goal. Engaging in health risk reduction practices is an important and viable option for older adults and is consistent with age-sensitive practices. So what we would call harm reduction. Abstinence is not the goal. You're going to be helping them engage in health risk reduction practices, which could be you need to drink less. Risk reduction strategies lower health-related risk for older adults and can boost functioning. And it can also be a first step towards abstinence. Very important for older adults when you're planning treatment, especially for that late onset group that we talked about. So next sentence. So here are some brief interventions. Remember I said if your GMAS is 2, SMAS-G is 2+, you should do a brief intervention. Here are some brief interventions. Ask the client about future goals for health, activities, hobbies, relationships, finances. Adapt your feedback on the client's response to screening questions relating to drinking patterns and other health habits. Discuss how the client's drinking compares with that of others in her age group. Remember, showing them what is the national recommendation. Review definitions of what is a standard drink. Discuss the pros and cons of drinking if appropriate. Doing so can help you understand the role of alcohol in the older adult's life, including its role in helping them cope with loneliness. Give information about the effects of heavier drinking in a non-judgmental way. And discuss the client's reasons to cut down or quit drinking. Staying independent, having good physical health, keeping mental abilities can be key in this age group. So these are all examples of brief interventions. Next slide, some more. Offer information about drinking limits and ways to cut down or quit. Create a drinking agreement. Agreed upon drinking limits that are signed by the client and the provider are particularly helpful in changing drinking patterns. Discuss ways to cope with risky situations when the client may feel tempted to drink, either when they're lonely or they're bored or they're in a social gathering. And then always summarize your session. And my other rule of thumb for older adults, give it in writing. Write it down in plain English, what you'll have discussed. So these are all brief interventions which any of you can do. You don't have to be a licensed clinical psychologist or a social worker. Any of you can do a brief intervention. Next slide. And how many of you have heard of SBIRT? It is an evidence-based program which we have been promoting in Oregon at least for the last 10 years. Screening, brief intervention, referral to treatment. That's what SBIRT stands for. And it's next slide. And it's really based on this model that the majority of people who come to to you, older adults don't go to specialty mental health and specialty substance use programs. They come to their primary care doctor or nurse practitioner, fall into this kind of light to moderate use categories for alcohol use. So you can see here, lower risk is they don't drink much at all. Light is they're drinking small amounts. Moderate, they're drinking, moderate amounts of drinks. And then heavy is, they are dependent or they have a severe drinking problem. And if you see in the colors, the people who are drinking small amounts, they are considered at risk. And the people who are drinking moderately are considered problems. So that is the group that SBIRT tries to reach. Next slide. So low risk uses alcohol that does not lead to problems. These category people can set limits. They do not drink when they are driving. They don't take medications that is contraindicated, and they don't engage in binge. That's a low risk group. At risk group, the use increases the chances that they will develop a problem or complications. They consume 7 to 10 drinks a week. Remember, the recommendation is 7 drinks a week. Or they drink in risky situations. And they generally do not currently have health problems caused by alcohol, but if this pattern continues, they will. Next slide. The third category is problem drinkers. Here, the level of use has resulted in adverse medical, psychological, and social consequences. Although most problem drinkers consume more than low-risk limits, some older adults who drink even smaller amounts may experience alcohol-related problems. And here, a good assessment is necessary. And then lastly, we have the group, which is the problem drinkers' alcohol dependence, where it is, it is all the 4 C's come into play here, where, they have a severe problem with alcohol. So this is a good way for you to kind of keep that in mind when you're working with groups of people. Next slide. So what is a brief intervention? It is very time limited, 5 minutes to 5 brief sessions, and it targets very specific health behavior. So here we are talking about alcohol. We could be also doing it for prescription drugs. The goal is to reduce use. Simply that, which is harm reduction. Okay, and next slide. And here I'm showing you what are like the key components of a brief intervention in SBIRT. Screening, you do that audit tool, then you give feedback, then you look at motivation to change, then you discuss strategies for change, you negotiate an agreement, you follow up or you give a referral, and it continues in that way. That's what a brief intervention is. Next slide. And I'm just giving you here, some more how you give feedback, to someone in a brief intervention. Present the information based on labs, exam, screening instruments. Increase awareness of adverse consequences. You're drinking more than the recommended amount. Here is what the US government recommends. If you continue down this path, it can make your diabetes worse or affect your mobility. You would be at risk for falls or whatever you decide. Then help make the case for change in drinking or medication use, whatever it is. Okay, next slide. And this is just another way of looking at SBIRT, like what we were talking about. As you can see at the bottom of the pyramid is abstinence. Then it goes to low risk drinking, moderate drinking, high risk drinking, and then alcohol use disorder. And it gives you exactly what interventions you need at each level. Okay, I just thought this was a good way to conceptualize it and something that you can carry with you as busy clinicians or case managers. Next slide. Formal motivational interviewing and motivational enhancement therapy aim to reduce ambivalence which I call fear of change, by assisting the client to identify in his or her own words the pros and cons to make the change versus not making the change and maintaining their drinking. For the older adults, very important. The reason for change may include maintaining independence. You know what? I want to live in my home as long as I can. Optimal health. I want to be able to walk, and I know I need to bring my weight down and not, drink alcohol. And mental capacity. You know what? 3 of my friends were diagnosed with dementia. I want to keep my mental capacity. You can slip in information about alcohol and cognitive decline. So can you see the motivation for change for older adults is very, very different from younger people. So keep this in mind when you develop your programs and you develop your interventions. Next slide. Here are some motivational interviewing questions that you can ask. What do you think are some reasons for you to stop drinking? I want to live in my own home. I don't want to fall. My friend fell and had to move to a nursing facility. In what ways is not drinking important to you? I'll have more money to take my grandson to Chuck E. Cheese. How do you think your relationship with your daughter would be different if you were not using whatever, alcohol, marijuana, whatever? Your willingness to discuss the risks of taking more pain medication fits in with your health goals. I appreciate your willingness to talk about something that might be very uncomfortable for you. Can you see it's very non-judgmental? You're working hard to cut back on your drinking. What you set your mind to sometimes, you're determined, when you set your mind to something, sometimes you're determined to meet that goal. So these are some suggestions I'm giving you. Next slide. This is something, writing a change plan. That means once your client is all on board, you help them write a change plan. I will begin to follow my change plan on this date. My most important reason for changing my drinking are the situations where I will be most tempted to drink are some things I will do to say and to handle these situations are the people who can help me stick to my goal and the ways they can help me are. And then you sign it. So it's a very simple plan which any of you can adopt and adapt in your work. Next one. The other thing, actually, it is called, one more, go back. Oh, sorry, did I miss it? Yes. Alcohol use drinking agreement. This is something else. Purpose of this step is to decide on a drinking limit for yourself for a particular period of time. Negotiate with your healthcare provider so you can both agree on a reasonable goal. For some people, it may be abstinence, not drinking any alcohol. As you develop this agreement, answer the following questions. How many standard drinks? How frequently? And for what period of time? And then you create this agreement. On this day, I'm going to drink this much, this frequently, and for this length of time. And then you both sign it. This is a simple alcohol use drinking agreement. This could be very helpful in senior communities where you have identified people with a problem, helping them write this and then showing them that agreement when you feel that they are not following it. Next slide. Something else is creating a drinking diary card, which would basically be like a, and you can download this free all over the internet. It's just like a week calendar for 1 week with days of the week, the date and the times. You keep a track. One way to keep track on how much you drink is to use a drinking diary card. One card is used for each week. Every day, record the number of drinks you've had. And this could be very good for all of you clinicians to help you in your assessment, because sometimes older adults may not remember accurately how much they've drunk when you ask them 2 weeks later. So telling them to please keep this card and bring it into your session. At the end of the week, add up the total number of drinks you had during the week. And my suggestion to you would be to actually, on the other side, print what is the national recommendations for a drink. Not just one drink a day that recommend, but also showing the picture of what is a drink. So it's constantly available to the older adult to review. Okay, next slide. How many of you have heard of ASAM? So, it's so in ASAM, many of us use ASAM to kind of do an assessment of what level of treatment, substance use treatment, our clients need. And I have just given you the numbers which come out of ASAM. So you understand when someone says, oh, he needs a 3.5 or meets 3.5 on ASAM, you know what it stands for. So basically, it goes from the least amount, which is early intervention, to outpatient, to intensive outpatient, to residential, to medical detox. Okay, so this was basically an informational slide. I'm not going to go over ASAM criteria for you, but I just wanted to give you this information for all of you who may not be familiar with ASAM, and you hear this, oh my, he needs 3.5, which means he needs residential. Next slide. And now, in the last 15 minutes, I want to cover some evidence-based approaches, so which are free for you to download from the internet. And at the last few slides, I have all my resources that I've used for this presentation. So one is this manual which comes out of SAMHSA, and it's called the Substance Abuse Relapse Prevention for Older Adults, a Group Treatment Approach. This was authored by two psychologists, Doctors Larry Dupre and Lawrence Schoenfeld. And they actually present what we call a relapse prevention approach. And they use cognitive behavioral therapies and self-management interventions in this group treatment approach. By the way, I have also used this individually. So they have next slide. It's a 3-stage approach. So in stage 1, they identify the client's antecedents and consequences of substance use on a typical day of drinking. These answers are then used to compose what we call a substance use behavior chain. And I'm not going to go into all of the details today. Suffice it to say, I just want to give you the information. You will have the resource, and let's wait for my last poll question. That is stage 1, okay? Stage 2, you teach the person to understand and be aware of his or her behavior change. And we use this ABC approach, which is antecedents, behavior, consequences. Remember, in the first part, you actually developed that. So these components describe high-risk situations unique to each individual. And then they are taught in this module, the ABC modules, to keep a weekly log of their use, urges, and whether or not they use substances following the urges. So that is stage 2. Next slide, stage 3. This is actually the meat of the program. You teach them skills necessary to avoid a lapse or a relapse. And there's a curriculum that trainers can use. And they include strategies, lectures, exercises, such as behavior rehearsals, role plays, homework, all of these to teach them the new skills. And here are the modules. Situations where you will be at risk, whether it is social or at home and alone. Negative thoughts and emotions, anxiety and tension and stress, anger and frustration, substance cues, coping with urges and self-statements, and lastly, preventing a slip from becoming a relapse. So that is stage, so it's a 3-stage program. So this is stage 3 where you teach skills. Free for you to download this book and the resources at the end of this slide. The next slide. The other big evidence-based practice is called BRIGHT. And BRIGHT is an acronym and it stands for Brief Intervention and Treatment for Elders. It is an evidence-based practice endorsed by the Administration of Aging and SAMHSA Center for Substance Abuse Treatment. So it's been vetted and endorsed by these 2 large federal agencies as an evidence-based practice for older adults. So what is BRIGHT? Next slide. Again, free to download, and I have the link. BRIGHT is brief intervention, consists of screening. So first it is screening, followed by 1 to 5 sessions of advice, education, motivational interviewing, and has been very effective in reducing older adults' alcohol problems, whether the intervention is delivered in medical settings, in older adults' homes, or in aging service sites such as APD offices or senior centers. Equally effective wherever they were delivered. Next slide. So in BRIGHT, they have a brief intervention. So, you're trained in giving this brief intervention, and they use this workbook called Health Promotion Workbook. Okay. And it's really taken, that workbook was really developed and modified from these free tips. They're called treatment improvement protocols, which are free for you to download. It was tip 26 and 34. So brief interventions in these work would include identification of future goals to improve quality of life. I want to be able to walk till I'm 80. Health habits, education about older adults and alcohol, all what I was telling you earlier, medication interactions with alcohol, consequences of drinking, falls, decline in cognition, motor vehicle accidents, all of that. Reasons to quit or cut down, handling risky situations, and medication management. And throughout, the counselor is using motivational interviewing techniques to elicit change. And remember, I gave you a whole list of those questions that you can ask. Discharge from this program is based on the completion of this health promotion workbook and retention of the material based on, obviously, the counselor's judgment. Next slide. Counselors are trained to use that relapse prevention program that I just talked about earlier, developed by those 2 psychologists. And again, they do what we call a functional analysis, which is that behavior chain to address high-risk situations, including loneliness, peer pressure, depression, anxiety, anger, all of that. Completion or discharge from the brief treatment was based on retention of knowledge and performance on exercises and quizzes. And this was used very successfully in multiple settings where older adults congregate or in their homes. Next slide. And so BRIGHT has a follow-up plan. Individuals who received this brief intervention or brief treatment were scheduled to be rescreened by phone or in person. Unlike SBUD, in which typically they receive only 1 brief or maybe 2 brief interventions, here they're followed for up to 6 months and rescreened at 30 and 90 days in BRIGHT. Okay, next slide. They use these screening to quantity and frequency were measured with the first 3 questions from the audit, which we talked about earlier. If drinking had occurred within the last year, the 10-item short Michigan alcohol screening test geriatric, that is the SMAC-G, was used, administered. The computer program flagged scores of 2 or higher, which we talked about earlier about the SMAC-G. So these were the 2 screening instruments used in the BRIGHT program. Next slide. In addition to alcohol screening, the short geriatric depression scale, GDS, which is a 15-question validated tool, was also used, and individuals with scores ranging from 0 to 4 points, no depression, 5 to 9 points, moderate, 10 to 15 points, high depression. A flag in the computer indicated signs of depression was triggered for anyone who had 4 or more. Individuals who had been flagged for depression in the absence of substance use were referred to a mental health service. Otherwise they remained in the program. And they were treated for their depression too. Next slide. These were the results. Statistically significant reduction in alcohol misuse, medication misuse, and symptoms of depression as measured on the GDS. Next slide. Okay, so those were the 2 big programs, that we are really wanting to promote, is BRIGHT and the relapse prevention program in Oregon. Next slide is detoxification. And no, if you can just go back one. It is riskier for older adults. More often than not, if you're 65 plus, most detoxification programs don't accept you. They tell you need to go to the hospital for detoxification because it requires maybe some observation and all of that. There's some more risks for delirium and seizures and all of that. So it's not as easy referring an older adult to a detox program. Next slide. But beyond detoxification, here are the list of interventions. Brief interventions we talked about, treatment, both psychosocial and pharmacotherapy, self-help, online and books, mutual help, which is your AA and SMART recovery, peer support, and very critical in this age group, also managing comorbidities, both psychiatric and medical. So if you don't have it within your agency, partnering with some other agencies which could have these other parts of what a holistic, comprehensive program should look like. Next slide. A word about medication-assisted treatment. Remember I said only 9% of all those people who need treatment ever get offered medication-assisted treatment, which is across the lifespan. So MAT, sometimes you may have heard the word MAT, that's what it stands for, medication-assisted treatment. In Oregon, we are doing a lot to promote MAT because of the opioid crisis. So I would highly, highly recommend wherever you work to figure out who are your medication-assisted treatment providers in your county or in the town where you live. Where is your OTP, your your opioid treatment program? Here are medications. You should offer medications to anyone with moderate to severe alcohol use disorder. Whether they're currently drinking, they're recently abstinent and experiencing cravings, or are at risk for going back to drinking because the cravings are so uncontrollable, and that they prefer medication along with psychosocial intervention. Next slide. Here, for all of you who may or may not know, I'm not a pharmacist, so I cannot speak at length. I think Angela said that Dr. Maureen Nash may be speaking on these, but here are FDA-approved medications for alcohol use disorder. The first three: naltrexone, acamprosate, and disulfiram. And then non-FDA approved are topiramate, gabapentin, and baclofen. So I'm not going to speak more about it, except this should be offered as a portfolio of evidence-based practices. You can't say, no, I don't believe in medication and substance use. We are not interested in your belief. This is evidence-based medicine. You won't say that I don't believe in antibiotics, right? For some horrific illness you have. It would be unethical if you don't offer it. Similarly, MAT is one therapy among many, and very effective therapy. Next slide. And I want you to be very cautious about the language you use. Stop talking dirty. Stigmatizing language reinforces negative stereotypes about drinking and drugs and addiction. And person-centered language focuses on the person and not on the substance use. He's an addict, or he's an alcoholic. That is not person-centered language. It is highly stigmatizing and reinforces stereotypes. Next slide. So words matter. Language can be used intentionally or unintentionally to perpetuate stigma. The language used towards people who use drugs or alcohol and people with addiction includes many stigmatizing terms, which have shown to increase negative attitudes among public and among clinicians. Example includes words like abuser, addict, dirty, dirty urine. There are also more subtle ways that language can be used to frame issues related to addiction or substance abuse that enhance stigma. Nationally, there has been an growing awareness around the importance of language and the need to use medically appropriate person-first terminology. Changing our language is a crucial component of reducing stigma to improve the lives and health of people who use drugs or alcohol and people with addiction. Can you see that? Who use drugs and alcohol, not change the life of alcoholics and drug addicts. So words have power. Next slide. So what can you do? All of you people who have spent this morning with us, what message, what information can you take back to wherever you work? Raise awareness of the issue of alcohol-related harms among older adults, and that this harm is exponentially compounded because of aging. So raise awareness in your communities, whether it is through psychoeducation, whether it is through treatment groups, whether it is through public service messages. Get the word out. I told you 10% have had a binge drinking episode, and 3% have had serious problems with drinking. Increase community and individual resilience to alcohol problems by reducing high-risk drinking in older adults. Remember, we talked about what are those protective factors. How can you promote that to not just build individuals that are resilient, but communities that are resilient? For example, we talked about boredom, lack of purpose, social isolation. What can you do as a community to mitigate those risk factors where you're promoting protective factors instead? Lastly, community service providers recognize, that means identify people. And how can you identify people? By screening and assessing, and respond through education and treatment to alcohol use disorders, substance use disorders, and their related harms. So these are all things that you can do. And if any of you are interested in how do you increase community resiliency, contact Angela, to see what, if anything, are some community level work that you can do if you're from Central Oregon. So this is my challenge to all of you who are here today. Some of you may be solo practitioners. Some of you may think, oh, I'm just a therapist in a community mental health program. At the very least, elevate this when you go back to your organization, that we need to routinely screen and assess for alcohol use disorder in older adults. Next slide. And so my message is recovery works for all ages. Even though we don't have age-specific programs, we should have. Why we don't have is multifactorial issues. Why we don't have, we should be. And next I have all of the resources that I referred to. Next few slides, Kelly, if you can move. The next one. And so you can go through all of these. All of them are free to download. And at the very the second to last slide, Kelly, are the tips. Those books that I'm saying is free for you to download from SAMHSA, and the one on top in blue, Bright, that is the entire Bright curriculum. I've given you the link there, and then the other two tips that I mentioned. So these are all free. All of them are free. Next slide. And before we move to question and answer, Kelly, I'm going to ask you to just put our last poll question up. And the question is, are you interested in being part of a small community of practice group? That means we would create a small community of practice group. It would be virtual, where we would look at all of these treatment modalities I talked about. How can I develop a psychoeducation program? Maybe we can even work on creating a psychoeducation program using all of these different evidence-based practices. Or how can I implement Bright in my community? So I am interested with Angela, to create this community of practice in the Central Oregon area, or for whoever is on the phone. So if you can answer yes, no, and if you answer yes, if you can put your name in the chat box saying I'm interested, so then we can reach out to you. Let's give it another minute, Kelly, and then let's see the response. Yes, we can see the response now, Kelly. Okay, well, I am thrilled that that 20% of the group is interested. So please put your name in the chat box, and we will be in touch with you to see how we want to develop this. So thank you. And very lastly, thank you all for being such an attentive audience. I hope I have given you some new information in terms of data, risk factors, protective factors, more importantly, screening tools and treatment that you will be able to take back and use wherever you are in your practice. And I have also included my email address here. I welcome emails from you after the training. If there is something you want an additional resource on or clarification, I'd be very happy to correspond with you. With that said, thank you, Angela. Thank you, Kelly. And Angela, we have about 10 minutes for questions, comments, whatever people want to do.
Yes. First of all, can you confirm that I have audio?
Yes, you do. Very clear.
Good. I was a little unsure of that earlier. So we do have a few questions. Let's see. Some of you used the chat box and some of you used the Q&A. So I've got to go back in and search our chat box as everybody's signing out to cherry pick a couple of those. And there was a question about, I know from Natasha Sanders, I know you spoke at great lengths about alcohol. Can this information be applied for other substances?
Yes, absolutely. It can be. The treatment interventions are the same. You know, the two evidence-based practices I spoke about? Yes.
Mm-hmm. Okay, wonderful. Question from Kristen Lucas. How do rates of addiction in older adults in the US compare with other countries? Do we have that info?
Good question. You know, I will not be able to give you a good answer on that. So I will have to look that up and let you know. I can send the information to Angela, whoever asked that, or you can write to me directly with that question and I can give you that information.
That sounds like a good plan. Then we have from Bridget the question of, are the assessment tools available to the public?
Yes, it's free to download, but the public should know what the screening tools are. You know, they need to know the name. Like Audit is free to download. So
Okay.
also the SMAST or the SMAST-G, you can just put it in, you know, in your browser and it'll come up. So they're in the public domain. That's what I mean. It's available to anyone, including people, you know, older adults themselves.
Thank you for that. Thank you for that. And then Bhavika, forgive me if I didn't do a good job with your name, but I believe it's Bhavika who just threw out an observation to all panelists that she would love a session on medication substance abuse. I'm sorry, every time somebody puts in another statement, it flips the screen on me. So such as benzos, their implications, assessments, and treatment. So that is something for us to follow up on in 2021, which we are working on our trainings, and we are going to try and give you all a good selection of not just the concept and the theory, but also the behavioral piece of things. Question from Dustin. Actually, it's a statement, excuse me. Dustin says there's an app available for your phone to walk you through the SBIRT process. Now, several of you have asked about getting the materials from today's training. That's why it's good to create an EADS account, because we load all of the PowerPoints, whatever handouts a trainer wants the group to have, we load all of that into EADS. And just because you don't need CMEs doesn't mean you can't use EADS to get certificates of attendance and also to keep some of this in one place. One of our participants was bemoaning the fact that she can't get CADC credits. I believe CMEs actually will fly for your board. I am waiting to see if, yes, we do have a few more questions. We have from anonymous attendee, national resources for older adults that are low income and with no family support, lonely in other words, especially during COVID times and with no computer. Agencies which main goal are calling to check in and provide emotional support, ? Okay, I could read this one of two ways. Sounds like maybe there is a request for national resources for the issue of social isolation for older adults. And then what agencies are out there whose main goal is to call and check in and provide emotional support? And we were having a slight discussion on this shortly before we started the program. And Nirmala has some resources, which would you mind sharing again, not just the loneliness line, but some of the others that we spoke of.
So one is a Oregon statewide senior loneliness line. And Angela, you are welcome to send the link later. I don't have it handy.
Okay.
Which is a free statewide resource funded by the Oregon Health Authority. And as of November, we have a new emotional support line for all Oregonians, regardless of your age, for COVID-19. And it's called Safe and Strong Oregon. And I can send, Angela, I can send you the link.
Great.
It's a free telephone call that can be made, and then you are triaged depending on what your needs are and appropriately connected to resources. So senior loneliness line, the other one is the Safe and Strong emotional support line.
So what we will do, because not everybody's interested in getting an EADS account, it would be helpful if you all would, going forward, if you're going to take any more trainings or presentations with us, it just helps us cut down on the number of emails we send out to you. We will include some of those links and also the PowerPoint. We never withhold any of the resources from our folks. All right, folks, I am scanning our questions in our chat box. I think we've got everything answered. If not, reach out to me. I am happy to get you squared away. Thanks for joining. We hope that we'll see you in a couple of weeks, November 5th, for our training on the older adult and suicide assessment and prevention. That one also comes with CMEs. All right, over and out. Thanks again. Bye-bye.